Okay. So we are going to have some commentary today from somebody I'm so excited to introduce, because I will say that in the, in the 10 years since I finished the fellowship, we have been essentially in the same city and have never actually worked together. But we are part of a very rich group of OBGYNs who completed the fellowship, who we would like to have a picture with actually after this panel. So do not leave, because there's a lot of us. It's very exciting. So Allison Bryant is an associate professor of Obstetrics, Gynecology, and Reproductive Sciences at Harvard Medical School. She is entirely educated within that system. Took a short little jaunt to California, where she was at UCSF doing some of the work that she then came back here to do, which is looking at Black infant health and women's health. On the San Francisco Department of Health Women's Advisory Board. Here at MGH now, she's a vice chair of Quality, Equity, and Safety in the Department of OBGYN, and this is a role that she designed, because we hear a lot about quality and safety. The equity is the part I imagine she stuck in there, in an effort to try and underscore the role that equity in healthcare plays in terms of creating quality care across how we provide health to our patients within institutions. There's a lot of other stuff on here. I think most notably, you see a lot of stuff about ACOG, which is our both legislative and clinically, our clinical advising organization. They set our guidelines, and she actually has co-authored the Alliance for Innovation in Maternal Health, Reducing Peripartum Disparities, Safety Bundle. So all of those things that we're actually trying to institute and our review and guidelines around that were co-authored by Dr. Bryant.
So good afternoon, everybody. I am honored to try to close out this session that has been amazing. It is not an easy position to follow all these amazing and dynamic speakers. One thing I will say is that I am not in the least bit spontaneous, so the notion of sort of spontaneously commenting on anyone's presentations was fearful to me, so I did present some slides that I will use today. But I think it's been a really powerful afternoon, and what I'd love to do is to maybe contextualize some of the things that we've heard and think about how we can think about them, things that each of you can do when you go home today and go back to your institutions, but also thinking sort of on the national and sort of even international scale. So as we've heard, really there's been a sort of an overweight perhaps of the maternal here, which I think has been really sort of appropriate. I have no financial disclosures. Those who know me know well that my one disclosure on every talk I give is that I'm a native New Yorker, so I talk real fast. So I have like 40 slides to get through in 15 minutes, and I have no doubt that I'm going to do it. Also, I'm like hyped up on Sudafed, so I should be all set. This is my other disclosure from last night. So those of you who are my Facebook friends will know that this is our guinea pig that we have had for 17 days that fell on the floor and sustained a femoral fracture. So if you see the x-ray, that was last night at 9 p.m. I was at Angel Memorial in Waltham, sort of, expediting now a transfer to the quaternary care Angel Memorial in Jamaica Plain for an open reduction fracture. People who know me from New York have said, you've been from New York City a long time when you allow a rodent into your home, and now I have done so much more. And the question is, how did I get to this place? And one of the things I would say is that motherhood changes you, right? So motherhood changes you. I've been blessed that motherhood just changed me for the better, but we've talked a lot about today about motherhood that has caused harm for women, and particularly women of color. So I want to talk a little bit about that. So also when I give talks, this is oftentimes the first slide of my talk. So this is an issue of the Boston Globe that was from 2002 that still sits in my office today. It's my personal kind of aha moment about disparities. So it sort of says, infant mortality of Blacks on the rise. I was a chief resident at the time in the OBGYN program here, learning much about clinical care, and this very much resonated with me, but I knew that I wasn't going to hear much more about this in my maternal fetal medicine fellowship, and that was perhaps the inspiration for actually doing the Commonwealth Fund Fellowship as the second year of my MFM fellowship. Those who know me well as well will know that it was not that hard with my OCD and sort of, hoarding to find the exact USB drive on which was saved my practicum presentation from 15 years ago. Thank you very much. Thank you very much. And so 15 years ago, May 6, 2004, I presented on the impact of the Medicaid family planning waivers on racial disparities in pregnancy outcomes. And what I tried to convince the audience of in my background slide was that infant mortality was the proxy for the health of a community. And that infant mortality really was the barometer for the health of the community. And what we've all learned today, I think, is that's really not the case. There's a new metric in town. And really how a community treats their women, how they treat their mothers, really says a lot more about the character of a community. And this for us really is our great national tragedy, and this is our great national embarrassment, these disparities that we've seen. I often have patients who say to me, they know I have two boys. They say, Dr. Bryant, are you going to try for the girl? And every time I hear that, I think about this big orange bar, right? So this is 0.2% chance of death. That is me, right? African-American woman over 40. I'm not naive enough to think that my sort of upper middle class or my education is going to protect me from that statistic. And so that's what we've been talking about here today. We heard a little bit from Dr. Klerk really about pregnancy-related causes, so hemorrhage, emboli, sepsis, but really that we should need to be thinking as well about the things that dwarf that, so the pregnancy-associated causes, because there are disparities in all of these, and we tend to talk much more about the disparities in pregnancy-related causes. This has been sort of echoed a lot in our own professional societies. So in the maternal fetal medicine world, we really were going far left on the fetal side. So, a lot of stuff on prenatal diagnosis, a lot of stuff on sort of growth restriction. And about 7 years ago, the society sort of reined it in and said, we really need to put the M back in MFM. And so I think that on a national stage is where we are, and that's what we've heard a lot about as well today. I did sit on the ACOG Committee for Underserved Healthcare for Underserved Women, and so I had the pleasure of revising the committee opinion on racial and ethnic disparities in healthcare. And what we really wanted to highlight were those disparities that were egregious. We wanted to highlight those things that we didn't hear that much about. But in particular, what was important to me was to really talk to the provider about their role in terms of causing and perpetuating some of these disparities. So this is a rubric I tend to use from the American Journal of Public Health, and what I think is important is really talking about the role of the provider, talking about what we've heard today, the role of the place where the provider and the patient meet at the level of clinical encounter. What's missing from this, though, is the structural factors, right? So if we really played this to scale, the structural factors would dwarf out everything, but then you wouldn't see anything, so I put it in the corner. And so what we've heard today really are two distinct panels talking about changes that we can make within the context of the healthcare system, but also the things that we can change in the level of the community, and that pregnant women sort of float in between the two. But truly, if we think about it, pregnant women live much more of their time in their communities than they do in the healthcare system. So while we need to work together, we really need to be investing much more in the care and the attention that we're paying to community-level interventions. You just heard that we were part of this effort to create a patient safety bundle around reduction of peripartum disparities. And this was something that we were really quite proud of. So the Council for Maternal Safety and Maternal Health created a number of evidence-based bundles, and they really started with the big three, right? So hypertension, hemorrhage, VTE prophylaxis. And yet they elevated disparities as being an equal threat to maternal health as those other clinical conditions. And so our job was to try to create sort of actionable things that we could do to sort of reduce peripartum disparities. And you've heard a lot about these today, particularly from Dr. Molina, talking about things that we can do in the setting of the healthcare system. And so I just want to talk a little about some of those things that we do in our hospital that you could take back and do for yourselves. So we, as you heard, I created this topic. I said I would take this job of being the Vice Chair of Quality and Safety, but only if we could call it the Vice Chair of Quality, Equity, and Safety, right? So there is no quality care without equitable care, and we hammer that home with our providers. So our job is really to raise awareness of these inequities. So that's one of the things the bundle says that we need to do. This is a picture of my door. So just talking about our own statistics in our hospital, right? So African-American women are more likely to be readmitted. We present that at every QA meeting that we have. We ask everyone to talk about the race, ethnicity, the language proficiency, and the insurance status of the patient every time they present at QA. So if someone's had an adverse outcome, you're presenting all of those things, and we should be thinking about how those things might have influenced the care that you received. Also, I just want everyone to sort of think about data collection. So we heard a lot from Dr. Klerk about data this morning, or earlier this afternoon, and really the value of self-report. So I challenge you guys all to think about in your own institutions how this data comes to be. These are my children, who people might say are perhaps ethnically ambiguous, right? So if you're in the pediatrician's office and the front desk is assigning them a race ethnicity, how do we know that they are getting that right? And so I have multiple occasions tried to challenge the MGH registration line to see if they get it wrong, and they never get it wrong. They always ask me how I want this listed. They asked it first in an open-ended way, and then if I can't, they give me prompts. When I say that I want them listed as biracial, they ask me which I want to be listed first. Of course, I say African-American, and they do it every single time. And so what I would challenge you, because I think that is not happening across the country, and if we don't have adequate data collection, we are nowhere. So I would say go back to your institutions and figure out how this is collected and see if you can make that as a change. We heard a lot about bias, so we have done our own sort of implicit bias training. We required all of our providers, all of our environmental health, nutrition services, everyone needed to do an unconscious bias training, anyone who touched patients in our department. we required our CNM and our MD providers to do an implicit association test, and we leveraged things like a quality incentive bonus to get it done, right? So people have limited amounts of time, but these are things that are important and can be incentivized. And then we continue those discussions in our workplace. So we had a race and ethnic town halls, and then we had the YWCA Boston come in to do a race dialogues training with our frontline staff as well as for leadership in our department. We heard about the pipeline, about workforce diversity. So this is my graduating class from 1998. That's me in the front over there. That's Hillary Clinton, 3 people down. She's the first person who called me doctor. Big sigh. Anyway, there were 36 black people in my class at Harvard Medical School, which is a feat that I do not think that HMS has repeated. But it's not always just about quantity, right? So we are our residency program as well. This is one that attracts a lot of underrepresented minority medical students. And what we've learned is that your experience in training is just as important as the number of people that are around you. And so we need to do a better job of taking care of the folks that we are training. And because certainly, how we treat each other reflects how we treat our patients, right? So we can't think that we cannot be good to each other and yet also be good to our patients. We are also starting next month to collect microaggressions. So we're going to have an anonymous reporting system for all of our staff. We're thinking about heading out to our patients that they can sort of report the things that are happening to them on a daily basis that make their lives challenging to work at MGH. And then Rose and others have talked about advocacy. So there is a place. This is the time. This is the moment. These are our legislators who really are primed to hear much of this. So ACOG had its Congressional Leadership Conference a couple of weeks ago. Dr. Zara, Dr. Molina were there with Ayanna Pressley, we ran into Ed Markey in the hall. Everyone is engaged in these topics. And the asks this year really were around maternal mortality, around some of the bills that you've heard before, moving beyond 1318, which is just the authorization of maternal mortality committees, but really thinking about how can we fund the PQCs, how can we fund AIM? How can we do implicit bias training? How can we incentivize those things at a national level? You heard from Dr. Grant a little bit about the challenges of hypertension in one hospital. We need to scale some of this work up. So this is from the Illinois Perinatal Quality Collaborative, where they, over time, once you can leverage the power of a number of hospitals, rural, community hospitals, academic medical centers, everyone gets on calls and does work together in this collaborative way. They have shown a marked increase in the number of women who are treated adequately in a short time frame for hypertension. Same thing in terms of the number of women who are given patient education materials when they go home, and that over time their rates of severe maternal morbidity have gone down, and so this really works. We talked a bit about the maternal mortality review committees. I have the pleasure of serving on that committee. What I love about that committee is we really dig down deep into each patient, but what I think that the Lost Mothers series really did for us was to show us the women, show us their names. You could click on any one of these and get to people's GoFundMe page or their obituaries. We cloak the MMRCs in a little bit of cloak of secrecy, right? We're not supposed to say the name. We're not supposed to say the provider. And yet if we're working in through the lens of just culture, where everyone who showed up to take care of these patients were showing up to do their best, why can't we sort of lift that up and really learn who these people are? I'm going to breeze through this very quickly, but we heard a little bit about levels of maternal care. I think this is going to be important in terms of keeping women safe, but we've got to include the community in this, right? So if we are finding that particularly African-American women who are supposed to go to the level 4 center are not making it there, we need to use some qualitative work. We need to talk to women about what are the barriers to getting where they need to go, as opposed to this sort of top-down notion of you go to hospital A and you go to hospital B. This is from the New York Times that said why Americans' black mothers and babies are in life or death crisis. The answer to disparity in death has everything to do with the lived experience of being a black woman in America. What I think has been powerful today is about hearing people's stories. We keep hearing how black women are not listened to, and we have heard really some powerful narratives, and that needs to be a great part of this work. Racism, not race. We heard a little bit about this toward the very end, is that we need to stop saying that race is a risk factor. Really, the risk factor is racism. And so this quote comes from Jessica Roach, who has a doula organization in Columbus, Ohio. So this idea that the perception of black families related to constructs such as poverty, education, housing instability, and race as health as a risk factor continues to validate the so-called social determinants of health rather than address the structural and institutional policies that have created them and therefore the consequences of their impact. This is her web of causation, which looks a lot like the slide that I showed you, but really contextualized in the things that cause all of those things, right? So slavery, Jim Crow, the GI Bill, redlining, the 13th Amendment. None of these things exist without these historical contexts of racism, and so we really need to speak that name. This concept of reproductive justice will come up a couple of times. So Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So you heard a bunch about that in the sort of the community panel, and how we need to empower women to speak for themselves, to say what they want, and how we can help them to get there. And then lastly, just I think to bring it back to this notion of infant mortality that we started with, we can make change, right? So we heard that in Boston we are making change in terms of the decline in the Black infant mortality rate. So how did we do that? What was new, they said in the Boston Public Health Commission, was an explicit focus on the impact of poverty, racism, associated stress on health, and that was really sort of very much impactful. And so can we apply that same lens to our thinking about maternal health and well-being? And lastly, I would just say we need to strike while the iron is hot, right? Everybody's hot to trot on this. Elizabeth Warren's got a bill. Kamala Harris has got a bill. This you heard yesterday came out in the New York Times. We were like, really, yes, we knew this, but this was really about Emily Peterson's work that you heard about from Jean to Klerk about pregnancy-related deaths and the preventability of them. And so this is like the first time that all of these organizations and many, many more that are not on this slide are all coming together. So community-based, grassroots organizations, professional societies, all aligned in a similar way. And so we really need to move this needle. And so I thank you so much. I thank you guys for listening for the panel today. And lastly, I wish everybody a happy and a safe Mother's Day. And hopefully we can sort of keep everyone safe in this context of motherhood and have motherhood change them for the better. Thank you.